Okay. All right. We are here together, the two men of the menopause sexual medicine world, I think, on social media. So,
Yeah, pretty
for
much.
yeah, I'm Dr. Jordan Iman for people who don't know me, and then this is Dr. Corey Babb, and maybe Corey, I can let you introduce yourself.
Yeah, sure. So I am a board certified gynecologist. I'm a fellow of the International Society for Study of Women's Sexual Health, a menopause society certified menopause practitioner. And yeah, I own Haven Center, which is in Tulsa, Oklahoma. And we do sexual medicine, vulvar disease, and menopause and hormones. So that's what we do.
And I think I told you this when we met at ISSWISH, but I mean, you literally wrote the textbook on this topic, and I love your book. It's really, really just such a clean, useful, practical guide. So if there's any clinicians who are listening, it's really worth looking that up. But I think when we generated the idea for having this conversation, I think that a big focus of it was just the shared experience of being men in this field. And, I think that there's inherently a lot of questioning that goes along with that. So, I guess I'll just let you lead off. Like, would love to hear your experiences with that and, how that's come up for you throughout your career.
Funny, a couple nights ago, my brother-in-law is in charge of the surgical technology program at one of the community colleges here in Tulsa, and he invites me to kind of do these lectures once in a while. And literally, the first question was, "Why are you a guy in women's health?" And it's something like I don't know. I'm sure with your social media, people will randomly just kind of throw it out there, and it comes in. I think almost surges of it. But I mean,
Hmm.
it seems like it's now a big question. I think my dad was an OBGYN. I don't know if you've had any other doctors in your family, but
Yeah.
it was like no one questioned that of that generation, but it's I think our generation it's starting to be like, "Hey, why are you doing this?" Is there some ulterior motive or something like that?
Yeah, totally. And I think that the suspicion comes from a very reasonable place. I think that you and I both know, from our professional experiences and also just kind of, being people, I feel like in this world, that there are a lot of really, really, really toxic experiences that women have with men and particularly, male clinicians in women's health and, just broadly in the medical system. So I think it's coming from a very reasonable place. And personally, whenever it comes up, because it's the same sort of thing, it comes up all the time, both on social media and, in clinical practice. I've never found it to be any kind of personal affront. I do think that there are some clinicians that I've met that take it very personally. And I've never really understood that perspective because I feel like, this is such an important conversation. It's, a situation where people are even uncomfortable to talk to a female clinician about these topics, and I think that you should feel as comfortable as possible talking with your clinicians. But I think that hopefully through meeting people like Dr. Babb and I, you can know that there are good men in this field, who really do care and really are in this to try to do right and to provide the best care we possibly can. And I think that we can be just as empathetic as a female clinician can in this field. But I guess I'm curious, kind of what was your path to OBGYN generally, and then, very specifically doing sexual medicine, having your own practice. And I imagine it's like the only sexual medicine practice in Oklahoma, if I have to guess.
You are correct. Yeah, there's not a plethora of clinics like ours by any means. So, like I said, I was exposed to it from, I mean, growing up. Now, my dad, I would say, probably was 90% an obstetrician. Like he loved delivering babies. That was what he was about. And he was in solo practice, basically my entire life. So I remember
Hmm.
we'd go to dinner and we could only be like 5 miles from the hospital, and he would get called in and do stuff. So, I think that instilled this kind of very big push for women's health just from a political and kind of social standpoint from the beginning. And then in medical school, I originally, when I went to medical school, I wanted to do laryngology. Like my undergraduate degrees in music composition. So I wanted to help like people with voice disorders. And then I did some time with laryngologists. And I was like, man, I cannot do this. but I always loved hormones, I always loved endocrinology, and I loved the idea of a long-term relationship with a patient. It wasn't just someone that you saw once and, did something and then you said adios. So when I went into residency in general OB/GYN, I wanted to do reproductive endocrinology. That was like my thing. The infertility side was interesting, but I really
Hmm.
liked the hormone aspect of it. And then
Yeah.
ended up kind of my family's here, my wife's family's here. We ended up staying in Tulsa. There's not a fellowship anywhere close by. And so ended up joining on as academic faculty after that. But through that process, getting out in the real world and realizing, hey, there are people that have these questions and we don't have answers. We weren't trained at all
Hmm.
in this. I remember I think I got like 1 hour of medical sexual education in med school and maybe like another 1 hour in residency. So that's what really kind of provoked the interest into being like, okay, people have these questions and I didn't have answers for it. So joined up with ISWISH, got really involved with that society and then did the ISWISH fellow. And then that led into what was then NAMS, now it's just the Menopause Society and then the ISSVD for vulvar disease. And
Hmm.
just kind of knew that, Oklahoma and the surrounding area needed a specialized clinic for this. And so that's what kind of led eventually to the development of Haven Center. And we've been here will be 4 years in October. So yeah.
Amazing. Yeah, it's incredible, and I feel like I agree that you're maybe, kind of like one generation above me in terms of physician
I have much
development.
more white hair than you do.
Right.
Yeah.
I just haven't grown as much facial hair,
Okay.
um,
There it is.
but, um, unfortunately, I think that the legacy of what you're describing in terms of training that we received in residency has not really changed, at least in my experience. Um, I had one lecture about menopause in residency, in 4 years of residency. I had to miss that lecture because there was a big case that day, so I didn't even make it to the one didactic. And then the only other situation that it came up was in clinic one time. I remember having a discussion with one of my attendings about hormone therapy, and basically the broad summary of it was this should only be used in the absolute most symptomatic of people because the risks are so phenomenal that you don't want to put somebody at undue risk with such little benefit, essentially. And then honestly, sexual medicine, vulvar disease, I received zero training about that in residency. Like, honestly, it was going to my first ISWISH conference that just completely blew my mind and I feel like opened my eyes to all of these areas of women's health that we never learn about in practice. Um, I so yeah, I mean that was sort of, my path. I feel like to ending them in a similar place, but similarly, I feel like just this passion for wanting to do right by the women that we take care of and really actually have that knowledge to be able to help in a way that we really weren't trained for. It requires that extra effort and that extra care, I think, to take that extra step to do it. Because most people don't get that training, which is really unfortunate.
Like that. I mean, I'm sure you probably have encountered this too. You have patients come in and they've seen, well, I saw my regular GYN and they wouldn't do anything for me. I saw my family dog, they would,
Right.
and it's just, people are getting more and more information online, social media, and obviously there's some really good stuff and there's some not so good stuff out there.
Mm.
But being able to say, well, actually, here we have all these therapies, and here's the guidelines, and here's what is out there. Like you can really help people, and I
Yeah.
think that's the kind of one of the fun things, specifically with menopause medicine. I mean, like, man, people get feeling better so much. Like
It's
it's not,
amazing.
yeah, it's
It's
not a
amazing.
long term. Like, well, you'll feel better in 2 years.
Yeah.
Like it's
Yeah.
like, okay, here, take this progesterone and tell me how you slept last night. Like
Yeah.
so
100%.
I think that's really a cool aspect of it, and, we've seen this kind of Renaissance, that's what I'm kinda calling it, like,
I love
and,
that.
it's like, I mean, now, though, I think the biggest issue is going to be, who like, the bottleneck of who truly has kind of the expertise with this, because
Mhm, mhm.
we've had a bunch of people kind of even locally pop up kind of these, hormone mills and stuff like that. And it's like, oh man, are you doing the best medicine out there or are you just doing something to make a buck?
Right. I mean, 100%. And I think that, we both see that unfortunately there's a lot of not so scrupulous providers who, are doing things because it's lucrative right now because it
Right.
is so difficult to access this care. And, I think that, for people who are listening, I think that, it's really important that you're finding a clinician. My personal viewpoint is I think you should look for people who are part of ISWISH because I think that the people who find ISWISH are usually the people who really care and really want to learn that. I have maybe a little bit of a controversial opinion that, that NAMS or Menopause Society certification really is not that meaningful in terms of actual expertise in this topic. I think that it shows at least a dedication to an interest in it, but I think that you should still be cautious, when you're finding people, I don't think that that necessarily 100% indicates that this is actually a true expert in that topic.
No, I actually had the discussion last night with one of my colleagues, and it's like
Hmm.
it is I think it used to be more of a gatekeeper, but I
Yeah.
think nowadays, I mean, and when you try and get the message out, like, if you are trying to reach the greatest number of people, sometimes I think the message ends up being diluted.
Hmm.
Um, and I think that that's one of the things I like with the ISWISH fellowship. You have to show that you're doing this. And you have to have like, real dedication to that field, and they make you do, presentations and provide stuff,
Yes.
and
Right.
like, you have to basically prove that you know your salt. And not that Menopause Society doesn't have that in a similar way, but it seems like it's just like, hey, you want to be this, you want to be this, here
Yeah,
you go.
exactly. And also, I think that the exam really is not at all about hormone therapy. It's really basically about primary care in menopause. And again, like that's a really important part of that care. But I think that a lot of people from the outside kind of have this view of like, oh, they have this credential, they must be an expert in menopause management. But I don't think that that's actually necessarily true. So more just I think kind of something to do your homework, not to poo poo the Menopause Society, which I think of course does a great job of leading this this movement. Um, I wanted to return a little bit back to now, kind of being a man in this field, and I feel like I'm particularly interested in your perspective. You focus a lot on like vulvar disease and vaginismus, and I know that that's a really strong area. And I feel like these are usually the topics that people feel the most scared, or uncomfortable talking about with the clinician. Like, they might go years before they even bring it up, if then. So I'm just kind of curious, sort of like how you've navigated that, like, especially being a man in this field and, and understanding that there may be a little bit of a trepidation, in sharing information with a clinician generally, but then particularly with a male clinician. And, obviously, I encountered the same thing, but, this is really what you do full time. So I'm really curious about that.
The biggest thing is really trying to make the appointment as a whole as atraumatic, as kind of sensitive to that patient's kind of past histories as possible.
Yeah.
We spend, and obviously I'm seeing these patients in person. I mean, we
Hmm.
spend of the 60-minute new patient appointment, probably like, 50 minutes just sitting and talking. And,
Yeah.
I think when you do this, you kind of practice gynecology. You're
Hmm.
basically, like listening and trying to kind of, ask those questions in a way that's appropriate, that makes the patient feel that this is a safe place. And then I think when you
Yeah.
do exams, and especially for patients that have vaginismus, vulvar trauma, everything with that, making sure that you're really practicing kind of informed care
Hmm.
with that and saying, hey, I'm doing this and I'm doing this. And I know we use a vulvoscope that hooks into our office computer a lot of times. So patients actually see what we're doing.
Oh, that's great.
Um,
It's amazing.
yeah, and so I think taking that, it's not a mystery because that's not it at all, but, like, they can see when you're like, "Okay, look, here you can see my hand is on your leg," and,
Hmm.
sometimes when you're doing, like, with vaginismus patients, I've if we have to do a digital exam, having them actually kind of, put their hand on my hand, say, "Okay, if we're
Hmm.
gonna, insert 1 finger," you kind of guide things
Yeah. Yeah.
in,
Yeah.
and giving them the agency with that.
Yes.
I think it is kind of the only way I can imagine doing that in a successful way. If you're just like, "Well, here you go, and pop a speculum in," and that like, no, that's just gonna cause more
Yeah.
trauma.
100%. And I would say that on social media and also with patients directly, I've definitely had patients, that will say that, they prefer to see a male gynecologist. And, again, like everybody should see who they want to see. This is not at all an indictment of female colleagues, who are excellent. But I think that one thing that I've heard come up sometimes is that there are some female colleagues who sort of go about an exam or sort of, any kind of appointment with this perspective of like, well, I'm a woman, I've put up with this, so you should too. And that I think as men in this field, at least as kind of caring men, I think who are empathetic and trauma informed and really trying to guide that visit in the most supportive and open way possible. I think that maybe there could be a little bit less of that tendency. But again, I don't want that to be, a knock on our female colleagues. But that's just, one thing that I've heard from the patients who say that they prefer to see a male gynecologist is that there is a little bit of this sense of almost this like objectivity to it. But I don't know if you've encountered that.
And, that's something I tell my patients too. Like, I don't have your parts. I don't
Mhm.
know what this is going to feel like. So I'm going to try and make something that, no one is like, what I want to do today? Go to the gynecologist,
Right.
like
Yeah.
to
Exactly.
try and make something that is comfortable as possible.
Yeah.
And I think you're exactly right. I mean, it's all about trauma informed care. It's about making the environment, even of the exam room,
Yeah.
like as peaceful as can be, but just really having that idea that, I believe when you say this is painful or this is feeling pressure or whatever, I can't be like, well, I felt that it's not that bad,
Right. Right. Exactly.
So yeah.
I feel really lucky that in my first year of medical school, when we do like our doctoring course, where you sort of like just learn how to be a doctor, not really, the scientific stuff, but just like how to have a conversation with the patient, how to collect a history, how to perform a physical exam, all the basics. Which people might not even know that we really do that. But I feel so incredibly lucky that the person who taught me, her name is Dr. Sadie Alessio. She's an internist, I think, in Boston now. And she, has really, kind of led a lot of the national movement surrounding, using trauma informed practices. And I feel so lucky that I learned that from such like a young gestational age in my development. Because I had no intention of going into OBGYN when I started medical school. It was something that I decided on, much later in med school. But that practice, from the very beginning of understanding how to make a patient feel comfortable, how to give them that agency. I love the word that you use. And how to, kind of restore control to a situation where somebody often has had control removed, particularly as that translates to a pelvic exam. Um, I just feel so incredibly lucky that I had that because I think that learning that at a later stage when you've already built up all of these habits of the way that you speak and the way that you perform things is so much more challenging. And we can all learn and we all should learn. But there's always ways to get better. But I just think a lot of people I think don't necessarily go into that with that idea. Like I posted this video a couple weeks ago about the use of the words for me, which is like my most cringe words, possible in medicine. And it's so ubiquitous. And everybody learns this in medicine, that they learn, oh, take a deep breath for me. And it's just kind of this thing that this parlance that we all incorporate. And that was, something that I learned from a very early time in my medical training, that there's no reason to say that. It doesn't add anything to it. And all that it does is actually create the potential for trauma because you are sort of using coercive language in a lot of ways. So it's just one example of that. But I think that, we all should be so incredibly thoughtful about the things that you're saying when we're performing these exams, when we're, speaking with patients. And it is for me, I think the number one way that particularly I as a male gynecologist build trust with my patients is that I help them to have control over a situation that ordinarily people really don't have control over.
I 100% agree with that. I think the other thing, talking about with conditions, like using the term condition instead of
Mm.
disease,
Mm.
and like that's another one. Like I rarely, I try never to. I'm sure it maybe slips out once in a blue moon. But you're talking about for people that have these conditions or that are struggling with these symptoms, it's taking it away from being like you have this disease that is, and all the negative connotations with that to something that like okay, hey, here is a symptom of this that we can
Yes.
treat, and I think, I mean, even just kind of language of changing, STDs to STIs,
Yeah.
like But the linguistics of it is really fascinating.
Yes.
And I think if I were to not do medicine, I would have done historical linguistics because I love languages. But like the way that we speak, I think a lot of people don't realize,
Yeah.
you know. But no, to kind of you thinking about what you were talking about with your kind of early clinical experiences there in med school. I remember we had we were learning to do male genital exams. And I think I was like a resident. We had to supervise the first year med students with this.
Yeah.
And there was this guy, and he came in, and at the time when I was in training, Tulsa had a homeless population that the med school would often recruit, and they would pay them, they'd provide them lunch and things like that
Hmm.
to,
Hmm.
to basically be a standardized patient. And this guy, I mean, like, we were probably 7 med students in there, and so he basically they had us line up like the med students like an assembly line, and it was just like this guy, like, he's like getting hernia check,
Oh my
hernia
God.
check, and then it's like, "All right, digital rectal exam," and it's like,
And I feel like the ethics are so dubious there because it's like
"Oh,
this is somebody who doesn't really have a lot of choice, like he just like wants a
right."
meal, and then here he is getting all of these exam maneuvers that maybe otherwise he wouldn't have agreed to. Yeah.
Yeah, and it's just, things have changed so much since then, I
Yeah.
think, for the better with that, but, those experiences, I think, really stick with you and
Yeah, totally.
how you have to remember to humanize the person, like saying, like,
Yeah.
person-centered care, not patient-centered, because they are a person.
Mm,
So,
yes. Yeah. No, I love that. Yeah, I do agree that I do feel like there are kind of like these salient memories in the pathway to, I think especially to becoming an OBGYN. And I feel like one of my memories that I think just showed me how much I belonged in this field was, I was a third year med student and I was in the ortho OR. We were doing a hand surgery. And listen, orthopedic surgeons are wonderful people and they're great surgeons, but they're definitely, there's definitely a very strong bro culture, I would say, to say the
yeah,
least. I have a feeling that neither Corey nor I fit in very well with the orthopedic surgeons,
no,
um, but I remember being in the OR and we were sitting there and I was already kind of thinking about OBGYN at this point because I had the most amazing OBGYN mentor who I still just love so much and I owe a great debt of gratitude, Ginny Bass. Um, and we were sitting in the OR and it was a male orthopedic surgeon, a male scrub tech, a male resident. So, all 4 of us were all standing around this hand, sitting around this hand. All of the circulating staff, in the room were all women. Um, and there were multiple times that the surgeon, asked for something, in a way that a surgeon does. And, maybe like the circulator had stepped out or, I think that they were kind of new. But, long story short, like this was a person who was really trying the hardest, but maybe wasn't like the most talented person, at their job quite yet. Happened to be a woman. And just in between the surgeon asking for these things, under his breath, he was just muttering all of these misogynistic comments. And of course, I was like this little med student, in this OR. And I think one of my great regrets in life is not saying something, about how displeased I was, and how inappropriate it was. But I just remember in that moment being like, this is not at all the people that I want to spend time with. And also, I need to go into a field where I can contribute towards making sure that this kind of shit does not happen anymore. Because it's just like unacceptable to speak about a woman in this way, particularly among a group of men. And unfortunately, like that is just kind of a normal, expected part of society that like men can speak ill of women. And so that was, a huge salient moment for me when that really stuck with me in terms of like why I'm in this field and why I wanted to do this and like the people that I wanted to spend time with and learn from and the brilliant women that I wanted to surround myself with in the field of gynecology. Um, and it's like interesting, I feel like when you look back through your training, because I think that a lot of men who are in this field have those moments where they were like, this is something I care about so incredibly much that I'm going to do this thing that everyone else is saying, like, why would you do this? Why would you be a man in this field,
very similar experience, but I was in general surgery.
Yeah.
Uh, but I mean, same type of things, and they were the general surgeon. He'd called all gynecologists, a certain, slang for female genitalia doctors. That he's like, well, I'm going to call the,
Oh
doctors
my
to come
god.
down here and do this.
Unbelievable.
So.
Yeah,
But no,
I feel like I was just gonna say, I feel like there's also this general sense among, predominantly male surgeons in other fields that gynecologists are not real surgeons, you know? Like, this is, like, a popular thing that I feel like still goes around that, "Oh, a C-section isn't real surgery. Oh, vulvar surgery isn't real surgery. A hysterectomy isn't real surgery." And I've always, just had this thought of, like, okay, are you saying that because the surgeons are female or because the patients are female? And it's probably both, and neither one is appropriate. But I feel like we just need to completely change this notion because it's unacceptable for men, particularly in medicine, to behave and speak in the way that they do.
think about like gyn-oncs are some of the most badass surgeons out there. I mean, those guys can
Unbelievable.
they can
Yeah.
do anything, it seems like. I mean, they're like, "Oh, I'm gonna go do brain surgery,"
Yeah.
you know?
Totally.
But maybe not, I don't know. I've never seen one doing, neurosurgery, but, like, yeah, I mean, I agree, and even, it's on there is a for some reason, the algorithm on Instagram, there was someone who was posting stuff all the time, and it was memes about how GYN, surgeries and GYN surgeons, are not real, and it's like, "Oh, call the urologist, a bladder got injured, or call the whatever." And obviously, injuries can happen at any time during certain, no matter
Any
what
surgery.
field you're in. Like, I don't know why, there is, other than just kind of the misogyny with it, this like,
Right.
idea that like, hey, if you had someone who had 4 C-sections and her, and you're going in for a crash section on her for whatever reason. I mean, it's
Yeah.
like driving through a construction zone with pouring rain with no headlights in at night,
I've
you
never
know?
seen I've never seen a general surgeon have to get a gallbladder out in less than a minute.
Right. And you I mean, that, term uterus pumping half a liter of blood through it,
Right,
and so their blood's
sorry.
just flying everywhere, and they're like, "Ah, get the bovine." Like, we're like, "I don't care. Here's some blood,"
Yeah,
there's
exactly.
yeah,
Exactly.
so,
Yeah.
anyway.
I know.
So
And I think that one of the people I feel like on social media who highlights this so well is Dr. Jocelyn Fitzgerald, who is at University of Pittsburgh. And she's a urogynecologist, and
yeah.
she published a paper in the last couple of months, basically showing that if you look at the codes for the equivalent male procedure, in female anatomy, that systematically the RVUs, for those listening, which is basically the amount of money that you get for that procedure, is less, even if essentially surgically those are equivalent procedures. And it
Oh,
just
sure.
it just goes to show you just kind of like systematically, not just in kind of the like locker room boys chat of, typical surgery practices. Like systematically, like we as a society have devalued gynecologic surgery. And it goes back to, what I said earlier, like it's because predominantly the surgeons are women, and predominantly the patients are women, or all the patients are women. And either way, we've just decided that this is less valuable. And it's not even like, I think the counter argument that comes up is like, oh, surgeons are greedy, doctors are greedy, you just want more money. But it's like, it's not even that. Like, we're just saying like this should be considered just as equivalently as important as having a knee replacement, as having like any other procedure that you would have on your body, because the surgical risk, the surgical complexity, for in many cases going into that is just as high. And the predominantly female surgeons in this field should be compensated for that. And also, insurance should recognize that this is equivalently as important of a field as is anything else.
Yeah. My so I have 4 kids. I have 3 daughters, 1 son. My, firstborn was C-section. My second was a VBAC, so vaginal birth after
Mhm.
C-section. My wife hadn't got an epidural with that delivery, and the bill for the epidural was more than the 9 months plus the VBAC for my son,
Yes.
which is
Crazy.
crazy. But, there is a study, and I can't remember when exactly it came out, or basically that put this whole idea of, and it came from Harvard, if I remember correctly, but basically saying, like, valuing, like, here's the value on different procedures. And, I mean, a vaginal hysterectomy, it gets reimbursed less than a knee arthroscopy.
Yeah.
You're removing an entire organ through the vagina. It's the equivalent of taking an engine out through the tailpipe.
Mhm. Yeah.
And, and you're going to get, reimbursed less than someone who pokes a scope in a knee for, a little bit and looks around. So
Which I'm pretty
it's
sure
not
isn't even an evidence-based procedure anymore. So
right. Exactly.
yeah.
Yeah. So,
Yeah.
but evidence, whatever that is.
Right,
Uh,
exactly.
so it's something, but I think that part of, those of us that are men that do this, especially the ones that are, I think I'll call them the good guys with it. I
Yeah,
mean,
yeah.
we're all feminists, and I think
Mhm.
that's the thing that a lot of people may not realize when thinking about male gynecologists. If you're gonna do this and you're gonna devote your life to women's
Yes.
health, like, you have to care about it, you know?
Yes. Totally.
Um, and that's something I always kind of say when I get asked, "Why are you doing this?" Like, it's like, I've got, 3 daughters, my mom, my sister, my sister-in-law, my wife, like, they all deserve the best medical care in the world, and I will treat everyone like I treat would want my family
Yeah.
to be treated, and, like, you have to care about women if you're going to be in this field, and obviously, there are people that have abused it, but there are people
Yes.
with
Yeah.
that in every field too,
Yeah.
you know?
Totally. I couldn't agree more. I really do feel like, kind of being a male in this field is like, you get the body that you have, but there really is, kind of this calling to do this field well and to provide the best care possible in an area that I think otherwise is devalued. And for me, like that was I think one of the most important parts for me of choosing this field is I love the way that social justice is so infused into everything that we do as an OBGYN every single day, on every single individual patient encounter. And I think that most people who choose OBGYN, men and women, have this understanding that, like, if you could do anything else, you really should. Like, this is a really hard job. But what you get by choosing it is you get to be surrounded by the most amazing, passionate people. You get to really, truly fix issues for patients in a way that I think is difficult in other fields. And I think that just like you said, when we started this conversation, you get to have that long term relationship that is just one of the most special relationships that, you can have with another person. And I think it is so cool to be able to come to work every day and do that. And so the fact that I'm a man and I think you feel the same way is kind of irrelevant to that. Like just human being to human being, like this is the thing that I care about more than anything in the world. And it is just such an honor to be able to come to work every day and use the knowledge and the skills that we've accrued to help the people in front of us.
Couldn't say it better. So,
Yeah. Well, I think that that is probably a good place to close this out. For those who are watching who follow me, Dr. Corey Babb has an incredible Substack as well. Just the most incredible, detailed pieces about sexual medicine. A lot of commentary about the healthcare system as well, and kind of how that pertains to sexual medicine, which I think is just such an important part of that conversation too. So 100%, like please do go check it out and subscribe to him because it's one of my favorite Substacks. And I hope that this conversation was enlightening for all of you, especially the people out there who are like, why would a man become an OBGYN? I
yep,
think, hopefully you got a little bit of an example of the things that we care about.
pleasure. And I thank you for obviously inviting me to do this.
Yeah, this is great. To be continued. I'm sure we'll have many other conversations to have in the future, but it was a pleasure. Have a great weekend. Bye, Craig.